Kia ora, and welcome to this third and final installment on the saga that we have on acute cardiogenic pulmonary edema. By way of introduction, I just wanted to point out that managing this condition can be quite challenging. As paramedics, you're going to have to deal with severely ill patients who can be quite anxious and agitated and require treatments that are not easy to necessarily apply while patients are in that state. On the other side of the ledger, the fortunate news is that there's a small number of very simple steps that can be employed to assist in the management of ACPO. So this session will briefly review the tools that we use to estimate the severity of a presentation before we go on to review the techniques themselves. So let's move on with that. By definition, acute cardiogenic pulmonary edema is a severe presentation of left ventricular failure. Any change in the patient's baseline indicates an advancing dysfunction and is very likely to require some degree of treatment. The key point in assessing severity is recognizing the presence of hypoxia, altered mental status, and worsening signs of perfusion. Now, hypoxia should not be tolerated and be corrected with supplemental oxygen via a mask, but if saturations don't improve with this technique, you're going to have to use positive pressure ventilation with something like CPAP or a bag mask device that's been fitted with a PEEP valve. Patients that have a clearly altered level of consciousness require resuscitation. And again, the use of positive pressure ventilation via a bag mask, PEEP valve, and supplemental oxygen is going to be the first step. You can use the perfusion status assessment and the respiratory assessment tools to complete the severity assessment when you're not dealing with patients who have an altered level of consciousness or other severe symptoms. Auscultation is a vital skill in recognizing the character of the respiratory sounds associated with these conditions. You should listen and record whether the sounds are bilateral, the respiratory phase they're occurring in, and the height on the chest wall that you're able to hear them. Now, moderate presentations are likely to be characterized by patients who can comply with instructions and show signs of recovery or stabilization with the early phases of treatment. The procedural approach in this case maximizes venous pooling by sitting the patient upright, and should the patient's blood pressure be sufficient, administering some sublingual nitrates. Now, should sublingual nitrates have a limited effect or can't be used because perhaps the patient is wearing a CPAP mask, you can use glycerol trinitrate transdermal patches for a longer acting solution. And just as a word of warning, hypertensive patients should not receive nitrates, and likewise, CPAP may pose some risk to them. Let's go on to look at some of the more specific modalities and treatment. So we have three main strategies that we're going to look in the situation. We're going to concentrate on the first two, which is the management of preload and the management of hypoxia. So, reducing preload. Now, preload is the force that's applied to the ventricular wall before systole. And the most significant element of preload is going to be the amount of blood that enters the ventricle during the diastolic phase. Under normal circumstances, more volume means more stretch, which means a higher stroke volume during systole. With the remodeling that is part of heart failure, this equation no longer works, and an increased preload can actually cause the stroke volume to fall. If this happens to the left ventricle, the symptom that we're going to see is acute cardiogenic pulmonary edema. For these reasons, the standard approach to managing acute cardiogenic pulmonary edema is to reduce the preload, hoping that this is going to improve left ventricular performance. Reducing preload is synonymous with reducing the amount of blood that returns to the heart. To achieve this, it's necessary to increase the percentage of the total blood volume that's held in the veins, and this can be accomplished in two ways. Firstly, let's get the patient into a sitting position with their legs dependent. This allows gravity to push and hold blood in the venous reservoir in the lower limbs, The volume held in that reservoir does not return to the heart, and therefore the preload is going to be less, and hopefully left ventricular performance is going to improve. The second plan of attack is to use vasodilation, and we're going to use short-acting drugs that cause this dilation to occur and increase the size of the venous reservoir. In turn, again, this will reduce the amount of blood returning to the heart. Now, the archetypical drug that we use is glycerol trinitrate, and we use it because it has a rapid onset of action but a relatively short duration. Fortunately, if longer-term control is required, we can use transdermal patches to sort of extend the duration of this action. Glycerol trinitrate has a second advantage. It dilates arteries and in doing so reduces the pressure that the heart pumps against. So this is what we would call afterload. This reduces the workload on the heart and so hopefully it's going to improve its performance. So let's move on to how to manage hypoxia. Hypoxia is a state in which oxygen is not available in sufficient amounts at tissue level. Clinicians can detect its presence with the use of arterial oxygen saturation monitoring. So the assumption is if the arterial oxygen levels are normal, adequate amounts of oxygen will be available to the tissues. Typical saturation rates range from 96 to 100%. The thing to be aware of is that it only takes a slight drop in oxygen saturation levels to get a dramatic fall in oxygen content. By way of example, let's consider oxygen saturations at 99%. Normally this means that oxygen content is as high as it can be. That would be about 100 millimeters of mercury of pressure within the arterial system. If we were to drop that by 5%, let's get down to 94%, we'd be looking at oxygen content that had dropped to 80 millimeters of mercury. So a 5% drop in saturations has resulted in a 20 millimeter of mercury drop in partial pressure of oxygen. So a fall of 15% in oxygen saturation equates to a 50% fall in the partial pressure of oxygen in the bloodstream. Hypoxemia, that's low oxygen content in the blood, is defined as a partial pressure of oxygen less than 80 millimeters. So in terms of what we look at on an oxygen saturation meter, this is going to equate to saturations of less than 95%. So once saturation levels hit 94%, we really have to think about correcting the amount of oxygen that's available to the arterial system. In the setting of acute cardiogenic pulmonary edema, hypoxia is most likely to be caused by a combination of poor oxygen transfer through the edema in the lungs, and secondly, poor perfusion to the tissues as a result of poor cardiac performance. Improving arterial oxygen levels may require one or more of the following strategies. So first, let's increase the percentage of inspired oxygen. In technical terms, this is known as the FiO2. More simply put, we're just going to apply oxygen via a simple face mask or via a non-rebreather face mask. Our second strategy is to increase the atmospheric pressure within the airways. This is the force that's pushing oxygen across the alveolar wall. So more simply put, we're just going to use a positive pressure device such as a bag mask or a CPAP device to increase the pressure that drives oxygen across the alveolar wall. Our third strategy is to recruit more alveoli to participate in gas exchange for a longer period of time. Step 3 is normally done at the same time as step 2. So in the case of the bag mask device, we're going to attach a PEEP valve. PEEP valves are a spring-loaded device that the patient exhales against. They're calibrated in centimeters of water, which really tells us how much pressure is required to raise a column of water to a specified height. And the PEEP valves can be adjusted to deliver anywhere between 5 and 20 centimeters of water pressure. As the patient exhales, the PEEP valve creates pressure in the airway, and this pressure splints alveoli into the open position and allows for gas transfer to continue during the exhalation phase. With CPAP, this will occur because of the combination of the positive pressure that's generated by the device and the equivalent of a PEEP device that's attached to this. I just wanted to reiterate the fallback position. So when everything is going wrong or not working, our fallback position is to manage severe or worsening ACPO with a bag mask and a PEEP valve. So when positioning and when nitrates and when CPAP fail to improve the situation, or we're encountering a lowered level of consciousness, the priority should be to go to the bag mask device with supplemental oxygen and a PEEP valve. Now, in some cases, this might require the patient to be put in the supine position. However, under these circumstances, this might be preferable to worsening ACPO in a severely compromised patient, and at least we're going to get some gas transfer and some respiratory pressure. I'll briefly touch on managing shock. I think it's something that you'll encounter later in the degree, but just as an oversight, let's consider cardiogenic shock as a recognised complication of heart failure. So it can occur in the presence of ACPO, but often it won't. Management for cardiogenic shock is to use fluids to support the blood pressure and thereby support perfusion. But a lot of caution is required to avoid an exacerbation of ACPO by overloading fluid and increasing the preload. For this reason, if you're involved in this, you're going to use small boluses like 250 to 500 mils of fluid. And the lung sounds have to be monitored frequently to make sure that ACPO is not developing or worsening. There's a role for inotropic drugs such as metaraminol or adrenaline. They can be very helpful in this setting, and at the moment we would normally expect them to be employed by intensive care paramedics. Now, the handout that accompanies this has a little more information on all of these tools and the strategies that we've discussed to date. So remember, our go-to strategies are to reduce preload by sitting the patient up and having their legs dependent. We use short-acting vasodilative drugs to reduce preload and have the advantage of also lowering afterload. We've got two tools to increase positive pressure. The first of these is the bag mask device with a PEEP valve. So we're going to use a spring-loaded device that people have to breathe against to splint some alveoli open and to increase the duration of gas transfer across the alveoli. And for those services that have it available, we have CPAP devices. These are continuous positive airway pressure devices that are also excellent at this alveolar recruitment. That means they splint the alveoli open as well as increase the time that gas exchange can occur. They increase intrathoracic pressure, which helps reduce preload, and they also provide a little bit of left ventricular splinting, which can help stroke volume. And remember, when things aren't going well and improvements can't be achieved, or we're dealing with patients with an altered level of consciousness that require resuscitation, then our go-to device is going to be a bag mask device fitted with a PEEP valve and supplemental oxygen attached. The procedural approach in the ambulance guidelines in New Zealand pretty much follow this structure, so they're a good guide into how to achieve and when to achieve them. And this brings us to the conclusion of the presentations on acute cardiogenic pulmonary edema. I hope that this has been useful, and I hope we get the opportunity in class to discuss and practice the strategies that have been brought to light in this presentation. In the meantime, ka kite.